Intravenous therapy. Intravenous therapy is going to introduce liquid solutions and blood products directly into the bloodstream or other anatomical spaces that will readily absorb these products into the bloodstream. It can restore and maintain fluids and electrolytes. We can do blood sampling from many of the venous access devices, and it allows for transfusion of blood and blood components. Provides routes for parenteral nutrition or routes for medication administration. For medication administration, we know that we have direct access to the circulatory system, which will provide a very rapid drug action and can also help us achieve precise dosage calculations and flow rates. It will avoid pain and tissue irritation from intramuscular or subcutaneous administration or oral drugs that might irritate the gastric mucosa or could be inactivated by gastric juices. The dose can be titrated to achieve desired therapeutic responses. IV therapy can be continuous or intermittent. If it's intermittent, we also call that a saline lock, and that would be used when a continuous infusion is not necessary, but we do require venous access. And that way we can deliver fluids rapidly in the event of fluid volume deficit. There are multiple types of infusion and delivery methods. We can do it peripherally. We can do it through a central venous access device. We have intraosseous devices, or IO, which is used for a rapid access in emergent life-threatening situations if we're unable to obtain a peripheral vein access. And subcutaneous infusions will be used for continuous infusion of isotonic fluids to treat dehydration. Delivery methods, again, could be continuous. It can be intermittent, where we infuse a solution over 30 to 120 minutes with smaller volumes of maybe 50 to 100 mLs. These will be piggybacked into a continuous infusion line or infused directly into an infusion device. We can do push injections, where we inject a medication into a continuous infusion line or inject it directly into an intermittent infusion device. And we can do IV boluses. An IV bolus is where we're going to administer a medication or a fluid very rapidly over a short period of time. There are risks to IV therapy, and this includes bleeding, emboli, damage to the blood vessel, fluid volume overload, overdose because of rapid medication absorption, allergic responses or adverse effects, incompatibility to drugs or solutions, and catheter complications or interference with the activities of daily living. And IV therapy is more expensive than oral or intramuscular medications. The infusion system will include a solution container, administration set, add-on devices, and a flow control device. The solution container is a plastic bag, a semi-rigid plastic bottle, glass bottles, or syringes. The administration set is the tubing that attaches to the solution container and connects to the IV access device. It is available in different lengths and diameters, but all should contain a drip chamber, roller clamp, or slide clamp, an insertion spike, and a male lure connection, except for something like your extension tubing. The macro drop tubing, we have a 10, 15, or 20 drop per ml inner lumen of the tubing. So it is means for every drop that comes out of the tube, it would take 10 drops, for example, to equal 1 ml. The micro drop would be a 60 drop per ml set, and we generally just use that in pediatric therapy, although on occasion we might use that in older adult IV therapy also. Primary tubing is longer. It does contain 2 injection ports and may be specific to a brand of infusion pump. It will be used for primary or mainline infusions. Secondary tubing is shorter and it's used for secondary infusions. And then we have our extension tubing, sometimes called a J-loop tubing, that's usually attached to an intravenous insertion catheter. The tubing may have a vent between the insertion spike and drip chamber for rigid or glass containers, and that allows air to displace the fluid that's within those rigid containers. The insertion spike and male lure end that connects to the IV access device have to remain sterile. Some of our add-on devices might include those extension sets, filters, or stopcocks. The extension sets are often used for extra length in the IV administration set. Stopcocks are used for administration of intermittent fluids or medications through an administration set. Basically what it does is directs flow of one solution or medication to the IV access device while shutting off flow to the main solution. We frequently see this in the operating room, critical care, or trauma settings. Filters can be built into an administration set, for example, blood tubing, or it could be added to the administration set. It is required for infusions of blood components, parenteral infusions, and fat emulsions. The filter may require priming to remove air prior to connecting it to the client. We frequently will use this type of add-on device with pediatric IV therapy. Make sure that you refer to the pharmacy, fluid, or medication information to determine if there is a need for a filter. We also have needleless connectors. Today, in today's world, most of our IV administration sets are going to be needleless systems, but there are some that are still requiring a needle to access. So in other words, they have a little rubber stopper in the injection port. These needleless connectors can be attached to any port that does require a needle to access to make it a needleless port. Ports in the administration system will require strict disinfection measures prior to use to decrease the risk of contamination or infection. Chlorhexidine is going to be the cleanser of choice, but 70% isopropyl alcohol is acceptable. Cleansing of the port should always be completed prior to access and requires a vigorous scrub for 5 to 60 seconds. There are plastic caps that contain alcohol that may be applied to ports after access, and if you remove one of those caps, it does not require an initial cleansing. So flow control devices might be manual, mechanical, or electronic. Manual will include the slide clamps or roller clamps and flow regulators such as the ones in the slide above in the upper and left pictures. Mechanical might be the elastomeric balloon, which you see a picture of in the right picture. It might be spring-based or a negative pressure pump. Electronic will include infusion pumps and syringe pumps. These will help regulate the rate and volume of infusions, which improves the safety and accuracy of fluid and medication administration. They can also be programmed with volume and rate for continuous infusions and piggyback medications at the same time. Some infusion pumps can deliver more than one continuous infusion or piggyback. Electronic pumps do have alarms for air in the line or occlusion or completion of the infusion or a low battery. It is very important for nurses to be familiar with the function of the pumps that each facility has available. What's most important to remember, though, is even when we have that electronic infusion pump, we still have to monitor the client's IV site and the infusion rate. Factors that will affect flow rates will include the height of the solution container from the IV access device, the amount of fluid that's in the container, the viscosity of the solution, in other words, how thick is it, and client movement or position. A time tape is going to help the nurse know at a glance if the infusion rate is accurate. Basically, what this is a piece of tape on the solution container that the nurse has marked on to indicate what level the fluid should be at every hour. If a solution is administered using a roller clamp to regulate the flow, it is always going to be listed in drips per minute. And if a solution is administered through an electronic infusion pump, it will always be through mLs per hour. Excuse me. So we need to look at some different age considerations. With pediatric clients, the younger the child, the greater the risk of fluid and electrolyte imbalance, fluid overload, and congestive heart failure. LPNs are not allowed to perform IV therapy on clients younger than 12 years of age. Always be honest with the child and make certain that the child knows that the needle is removed and all that stays in place is going to be that little flexible plastic catheter. Tell the child why the procedure is necessary in terms that the child is going to understand. Do not tell the child that the procedure is not going to hurt. Rather, it's going to hurt just a little bit, but if you're really still, I'll be as quick as possible. Always have at least one other staff available to help restrain the child. We usually restrain above and below the potential insertion site. Frequently, when you're putting an IV in a child, you have to be able to hit a moving target. So be prepared. The child is often going to move despite being restrained. It really is not recommended to have parents restrain the child. We try and allow the parent to be the one to comfort the child. When we insert it, it should be performed in a treatment room to allow the child to associate their bed and their room with comfort and security, not a place where something scary like an IV is done. Use age-appropriate distractions to help take the child's mind off of the procedure. Consider topical anesthetic, but it has to be in place for at least an hour for full effect. 30 minutes will provide some effect. Topical anesthetic can cause vasoconstriction, though. With infants, we can use that oral high sucrose solution, often really effective. Excuse me. Try not to allow the child to see the equipment if possible before the actual insertion. So prepare the equipment outside the room on like an overbed table so then you can roll it in when you need it. You may require vein visualization tools to help find veins in a child due to the increased subcutaneous tissue. Make sure that you consider the age, activity level, and the reason for IV therapy when you select a site. As far as a tourniquet, we may only need the grasp of an assistant around the extremity instead of the actual tourniquet. After the procedure, make sure you praise the child's behavior, regardless of how cooperative the child was, and allow the child to talk about or play out their feelings. Immobilize the extremity with a padded board, but position in a manner that maintains normal joint configuration. Administration sets for pediatrics are micro drip, but we should always use an electronic infusion device to reduce the risk of fluid overload. Fluid administration should never be done by gravity, and in some cases we are only going to provide a limited fluid amount to be administered at one time. IV sites should be monitored at least hourly in the pediatric client. So when we're looking for sites, peripheral veins, the dorsal hand veins or the metacarpal veins can be used for all ages. We try to avoid using the dominant hand or the thumb sucking hand, and it will frequently require splinting on an arm board. It can interfere with the child's activity. We can use those dorsal foot veins in pediatric clients up to walking age. Occasionally, we can use it for older children in cases of trauma or burns. The antecubital fossa is generally an unsatisfactory site because we do have to immobilize this site. If we have to use it, it would be more favorable in older children, and always try to use the non-dominant extremity when possible. On anyone, avoid the inner aspect of the wrist because infiltration in this area can result in dangerous traumatic pressure on the radial artery and the radial nerve. Scalp veins are readily available up to approximately 12 months of age, but we really try not to do this in infants that are over 6 months because of increased hand activity. To dilate those scalp veins, we place the head lower than the rest of the body, which usually causes crying, and crying along with the lowered head will help raise those scalp veins. It's really difficult to distinguish veins from arteries in the scalp, so this is something that LPNs specifically cannot perform. The IV site has to be well protected to prevent dislodgement. Central veins are going to be recommended for therapy that lasts longer than 1 week. We can do the percutaneous central venous catheters. This would be jugular veins in neonates and infants, subclavian veins in an older child, and occasionally the femoral vein. We can also do the peripherally inserted central catheters or the PIC catheters. This would go into the basilic, median cubital, and cephalic veins of the antecubital fossa. Neonates and small infants, we can cannulate the umbilical cord or the large saphenous, superficial temporal, external jugular, popliteal, and axillary veins. So if we start talking about some of our older adults, we look at the immune system and physiological factors. The older adult's immune system is going to become hypo-responsive to foreign antigens, but hyper-responsive to itself. So we have a decreased number of circulating lymphocytes, which results in a decreased resistance to infections of the pulmonary system. These clients have decreased subcutaneous tissue, decreased cardiac output at rest, and this makes them more sensitive to fluid shifts with IV therapy. Their total body water amount is decreased, and the older adult is at an increased risk for fluid volume deficit and/or dehydration. Older adults have decreased tolerance to fluid excess or deficit, but are slow to show signs of these issues, requiring the nurse to monitor for very subtle signs. So we can administer fluids through subcutaneous tissues or intravenously. The subcutaneous route will be used for fluid volume deficits or to prevent dehydration. We can also give some medications through this route. It requires insertion at a right angle to the adhesive platform, which is pressed against the skin. The best sites for subcutaneous infusions will be the posterior upper arm, anterior or lateral thighs and abdomen, greater than 2 inches from the umbilicus, but sites have to include sufficient subcutaneous tissue in order to absorb fluids. Very important to cleanse the skin well, preferably with the chlorhexidine, and we have to maintain skin integrity. When administering fluids, we may need to rotate sites every 24 to 48 hours, but when only administering medications, we might be able to leave that site in place for 7 days. So with all IV therapy, we should use the smallest gauge and shortest length device available to effectively deliver the ordered therapy. When choosing sites in the older adult, we avoid flexion areas, areas that have bruising. When possible, we avoid the dominant extremity. Avoid those small spiderweb veins, and avoid hard sclerosed veins that might feel like a cord. Their veins are going to be more fragile, so when we're doing palpation or dilatation, gently palpate. Aggressive tapping can result in a hematoma because their vessels are so fragile and their tissues are very fragile. A tourniquet may not even be necessary. And if we do use one in the older adult, just apply it lightly to avoid over-distension of fragile veins. Alternatively, we can have an assistant apply digital pressure with the hand above the intended site and then release it once the vein has been entered. When we insert the cannula with the older adult, it does require the angle of insertion to be decreased because of the diminished subcutaneous tissue, and this will result in the veins being more superficial. Always apply skin traction below the intended insertion point. Usually the direct method of venipuncture will be most appropriate in the older adult. When we stabilize the cannula, we have to consider the older adult's fragility of the skin. Use hypoallergic or paper tape, and minimize the amount of adhesive used because excessive taping can lead to skin tears. As far as putting a dressing over the site, use the transparent dressing when possible. It will also help stabilize that cannula and decrease accidental dislodgement of the cannula. It also minimizes the use of tape on fragile skin. Site protective measures might be required for agitated, confused, or restless older adults. This would include maybe a long-sleeved gown, hand mittens, a flexible elastic netting to cover the site, a padded armboard, or the commercially available IV site protection devices. It is important for nurses to recognize that the older patient does have a lower tolerance to rapid infusions. Rates in the older adult are average 50 to 100 mLs per hour. A higher rate will increase the risk of fluid volume overload, but at times they are occasionally necessary. Care has to be taken to prevent runaway infusions. So really monitor your infusion flow rate and make sure the setting is accurate. And do not put the roller clamp where a confused patient might be able to get it and play with it. Assessment of these clients has to be ongoing. We're looking for evidence of fluid volume disturbances, especially overload, evidence of electrolyte imbalances. We have to do accurate I&O monitoring and frequent assessment of the venipuncture site. If an infiltration occurs, that fluid might drain away from the cannula insertion site, so be sure you look for infiltration below the insertion site or dependent to the insertion site because of gravity. We also need to monitor for an infectious process and expected therapeutic responses to any medications that we administer. So let's look at the cannula itself. There's a variety of venous access devices available. We have a catheter over the needle device, which consists of a plastic catheter attached to a plastic hub. It's most commonly used and good for most short-term IV therapies. So the over-the-needle device is the one we're going to see most often. It does use a sharp needle as a stylet, and that will help guide the catheter into the vein. The catheter is going to be slightly shorter than the stylet. You will see a flashback chamber. This flashback chamber is where blood will be seen once the vein has been accessed. There may be a push button to retract the needle after insertion. The stylet itself, the needle, will be removed following successful cannulation, and it will just leave that flexible silicone catheter in the vein. We also have winged infusion sets, also called butterfly needles. This is where a steel needle is attached to flexible wings that fold and are going to be held during the insertion, which is then attached to a small administration set. We use these for drawing blood or sometimes for a single dose infusion because there is a high rate of complication if we leave it in place. With the midline catheters, this is considered a peripheral IV device. This is usually placed in the upper arm, and they're 3 to 8 inches in length. They do require demonstration of competency to insert. This is not something LPNs will be doing. Again, inserted in the upper arm. It is considered a peripheral device, but it can remain in place for 1 to 4 weeks. We should not infuse vesicants, parenteral nutrition, or hypertonic solutions through these devices. The intraosseous device. Once again, this is used in emergent situations when a peripheral catheter may be impossible or difficult to achieve. It does deliver fluids and/or medications directly into the bone marrow. It's inserted into a large bone, with the upper anterior tibia being the site that's used most often, with the use sometimes of a special drill type tool or a manual device. The most used sites are going to be the distal and proximal tibias, the proximal humerus, and the sternum. Not saying that there are not other sites that can be used, but those are the most common ones, with the upper anterior tibia being the most common. The IO is contraindicated with bone disease, fractures above or below the site, infection or burns near the site, and a history of orthopedic surgery with hardware at the site. The most common complication is infiltration and extravasation and compartment syndrome. These devices can only stay in place for 24 hours or less because of the risk of osteomyelitis, which is a bone infection. Due to pain with the infusion, we may require the administration of lidocaine with IO infusions. It does require additional training to be able to insert these devices. So the subcutaneous infusion ports. Once again, these are used in clients that have limited vascular access, especially our hospice or palliative clients. They may have mild or moderate dehydration, and they may need continuous opioid administration or immune globulin. Again, it does require adequate subcutaneous tissue, requires demonstration of competency prior to insertion, and we can infuse volumes similar to other IV sites. It usually does require an infusion pump. The administration itself will have a short peripheral catheter inserted at a 45 to 60 degree angle. We always aspirate for blood return prior to use. The different sites, well, we want subcutaneous tissue. So maybe back of the upper arm, the upper chest below the clavicle, the anterior or lateral thighs, excuse me, or the abdomen at least 2 inches away from the umbilicus. We have to avoid joint areas and areas of skin impairment. We would also rotate the insertion site every 24 to 48 hours or up to 2 liters of fluid administration. If it's just used for medication administration, once again, we can rotate that site every 7 days. With central lines, these are placed into large veins near the heart and are intended for long-term use, infusion of potentially caustic drugs or TPN, multiple concurrent infusions, CVP monitoring, which is central venous pressure, and or blood sampling. Central lines can allow for greater dilution of fluids and medications because they are larger blood vessels. They can allow for rapid infusion of large amounts of fluids or medications. They frequently have multiple ports for medication or fluid administration, so we can administer multiple medications or fluids all at the same time. They do reduce the risk of peripheral vein irritation and prevents multiple peripheral IV sticks. So consider your central venous access device for solutions with an osmolarity greater than 900, anti-neoplastic therapy that will be over 3 months in duration, parenteral nutrition, inotropic agents, or high concentrations of potassium, long-term intermittent infusion therapy, pulmonary arterial monitoring, and failed or peripheral access, difficult peripheral access. There are some risks to the CVADs. They are going to be the same as the peripheral venous access device, but we add a couple. Pneumothorax is very common if the central device is placed in the chest. It is standard to obtain a chest x-ray following insertion. There may be damage to adjacent organs if a vessel is perforated. And there's also an increased risk of an air embolism, so it's important to always clamp the catheter before the catheter hub is open to air. CVADs require more skill, time, and resources, and insertion is usually going to be by the physician and can be done at the bedside. LPNs are not allowed to do blood sampling from central catheters in Kansas, but in Missouri, they have been allowed to do that. The different types of CVADs include a non-tunneled catheter, which can be inserted into the femoral, subclavian, or internal jugular vein. They are then advanced into the superior vena cava. These catheters are intended for short-term use in clients that require irritant or vesicant medications or hemodynamic monitoring. The peripherally inserted central catheters, or the PIC catheter, are used in clients that require therapy that is going to last over 6 days. It can be inserted by a clinician that has special training, including RNs. It is a central vascular device that is inserted through a peripheral vein in the upper arm and is then advanced to the superior vena cava. This site is often preferred because of the ease of access and its cosmetic appearance. Then we have tunneled catheters, which are inserted into the chest and used in clients requiring therapy longer than 1 to 3 months, such as for cancer. It does require a surgical insertion. The subcutaneous tissue will grow into the cuff of the catheter, and it helps anchor it in place and prevent infection. And the last type we talk about are our implanted ports. These are inserted into the subcutaneous tissue in the chest and placed under the skin. Then the catheter is advanced to the superior vena cava. It's going to be used for clients with chronic issues that require long-term but maybe intermittent therapy. It is accessed with a special non-coring needle in a right angle shape, and this type of needle is called a Huber needle. It cannot be accessed by LPNs. Peripheral lines are placed in the extremities or scalp of an infant and are intended for short-term use. Therapies that are not appropriate for short peripheral catheters include a continuous vesicant therapy, chemotherapy, parenteral nutrition, also called TPN, infusates with a pH that is less than 5 or greater than 9, or an osmolality greater than 600. Excuse me. Monitoring and assessment of the IV site and infusion should be regular and ongoing. We should monitor that site and administration set every time the nurse is in contact with the client. With non-irritating and non-vesicant solutions, we have to monitor every 4 hours. With critically ill clients receiving sedatives or that have cognitive deficits or a site in a joint flexion area, these clients have to be monitored every 1 to 2 hours. Infants and pediatrics must be monitored every hour. If we're infusing vesicant solutions in a peripheral site, we have to monitor these sites every 5 to 10 minutes. So this is why it should be done in a CAVD site. However, there are some situations where we don't have a central line in place and we have to have that vesicant solution going right now. So we use what we have available and hopefully get a central line in place as soon as possible. The assessment will involve assessing that we have the correct fluid, the flow rate is appropriate, and the volume is appropriate. Making sure of the expiration of the solution, the dressing is intact, that administration set is flowing or going appropriately. It's not kinked or pinched off. That the dressing has integrity. It's not soiled. Once again, it's intact. We don't see leaking under the site, etc. We're monitoring the actual insertion site and any client complaints. Monitoring will also include inspection of the entire system. We're looking at the solution, the label on the solution, the tubing and the label on the tubing, the connections, the site, the dressing and the label on the dressing, the flow control device, etc. Basically anything that is involved with that infusion. It's recommended that prior to, after, and or between infusions or medication administrations, that if we have an intermittent device, we flush it with normal saline. So it's always going to be a flush, medication, etc. Routine flushing with normal saline. We often do this twice a day. It is going to maintain patency of the device. It's normal saline, so it will not prevent clot formation, but it just helps keep that site open. After a device has been, or we've discontinued a continuous infusion, we're going to flush a device per facility policy. Understand that some of the central devices will require heparin flushes to maintain patency. Make sure that you always follow facility-specific policies for flushing. Many of these facilities are going to have the pre-filled 5 or 10 ml preservative-free normal saline syringes. The volume amount is usually going to be more than the amount of the internal catheter. Document every flush on the medication administration record. With dressing changes, we complete these per facility policy, but the infusion standards state gauze dressings have to be changed every 48 hours. Transparent dressings can be changed every 5 to 7 days. Now, if you have a gauze underneath a transparent dressing, that is considered to be a gauze dressing and has to be changed every 48 hours. We'll do dressing changes if the dressing becomes soiled, wet, or loose, or we see signs of infection. We always do a sterile dressing, and that will be applied to all venous access devices. So refer to your clinical checklist for appropriate steps on changing the dressing, but it's very important to maintain digital pressure to the cannula during the dressing change. We don't want to dislodge that cannula. Central venous access device site care and dressing chains will require the use of a face mask on the nurse and the client. Sometimes it is sufficient to just have the client turn their head away from the site, but a mask is preferable. Clients that have the central lines at home need to be educated on signs of infection and dislodgement and to report problems immediately. Once again, with maintenance, the antiseptic solution, the chlorhexidine is preferred. Prepackaged dressing kits are available. It's always sterile technique. And we should put a label on the actual site. This will include the date, time, and initials of the nurse that's performing the insertion and or dressing changes. And then we always document this procedure in the client's medical record. Now, back when I first started nursing, it was standard procedure for us to change the IV site every 3 days, regardless of how well it was working. But it is no longer recommended to rotate those peripheral sites as long as there's no complications anywhere around the insertion site. If we suspect a bloodstream infection, culturing the catheter tip should be considered. IVs that are placed in an emergency situation should always be replaced as soon as possible due to the increased risk of introduction of pathogens during insertion. You know, when you're in a hurry putting an IV in, you're not always paying close attention to proper technique. The patient's life is more important at that point in time. Any tenderness or pain with or without palpation may require changing of that site. Redness or blanching at the site, heat or coolness at the site, hardness around the site when we palpate it, leaking of fluids or purulent exudate at the site, and abnormal functioning. These can all be reasons that we may change a catheter site. Administration sets are going to be changed per facility policy, but usually about every 96 hours. So that's about every 4 days. Tubing is used to administer blood. This is going to be changed with every unit that's infused, unless we're giving it very rapidly. But packed red blood cells are usually going to be administered over 4 hours, and it has to be changed every 4 hours. For total parenteral nutrition, or TPN, or lipids, we have to change tubing every 24 hours. The tubings all should be labeled to indicate when they need to be changed. We should also change tubing if a different solution is prescribed, if a different site is initiated, if contamination is suspected. If we're using it only intermittently, we change it every 24 hours. If caps, caps are being used on the ports, apply a new cap every time you take one off. An IV fluid container should never be hung for longer than 24 hours per facility policy. Now, the fat emulsions, parenteral nutrition, and blood products will probably be changed more frequently. When possible, it's not always possible though, change the solution and administration set at the same time to minimize manipulation of the system and decrease the risk of infection. Now, every nurse needs to be familiar with the agency needle puncture and body fluid exposure guidelines. Infection prevention has to be in accordance with facility policies and procedures and federal or state rules and regulations. This means that PPE is going to be worn during all infusion procedures that potentially expose the nurse to blood and body fluids. Most of the time, this will just include putting on gloves. As far as infection control measures, the nurse should reduce the manipulation of all components of the entire system to reduce the risk of contamination and infection, meaning we're not going to be taking the tubing apart if at all possible. We don't access the injection ports any more often than necessary, etc. We have to do hand hygiene before and after all infusion procedures. No artificial nails when performing infusion therapy procedures. Tourniquets and all insertion equipment are to be single client use. Use gloves for catheter insertion. Scrub that insertion site with a skin antiseptic agent and allow it to dry completely. Do not touch the insertion site after you clean it. Ensure the sterile dressing is intact. Infection occurs more frequently in nutrient-rich solutions like TPN and blood. Use a new catheter for each insertion attempt. Examine equipment and solutions for integrity and expiration date prior to use. Ongoing assessment should be done to find signs of infection early. Do not contaminate the sterile ends of the catheter or administration set. All IV injection caps have to be cleansed with an appropriate cleanser and allowed to dry completely before accessing. As far as safety measures, all blood-contaminated sharp items, including but not limited to needles or stylets, surgical blades, and syringes, have to be discarded in a non-permeable, puncture-resistant, tamper-proof excuse me, biohazard container. Never attempt to put a discontinued saline lock and/or extension tubing in the sharps container. Always put it in a biohazard bag. By doing that, you will increase the risk of sharps to yourself by trying to stuff it in those sharps containers. So all biohazard materials, wastes, and drugs need to be discarded in the appropriate biohazard containers. So let's look at complications. Complications can be local or systemic. They can even be life-threatening and life-altering. So it's important to use appropriate techniques, frequent assessment to identify potential complications, and then implement appropriate interventions when we do note a potential complication. Prevention is going to be most important. Local complications can include infiltration, extravasation, phlebitis, thrombophlebitis, cellulitis, infection, occlusion, and nerve injury. Systemically, this can include air embolism, bloodstream infections, speed shock, circulatory overload, allergic reactions, or adverse reactions to medications. So infiltration is the unintended infusion of non-vesicant fluids and/or medications into the tissue around the cannula. The clients may report a burning or painful sensation. The site may look pale, edematous. It may be hard or cool to touch. Stop the infusion and elevate the extremity. It will require discontinuation of the site and obtaining a new site. Extravasation is the same thing as infiltration, only it's with a vesicant fluid or medication. This vesicant fluid or medication can cause tissue damage or necrosis. So prior to the removal of the device, we should aspirate the contents to help prevent further tissue damage. Remove the device, elevate the arm, apply cool or warm compresses, and administer an antidote if available. Inflammation of the vein wall is called phlebitis. Thrombophlebitis is going to be that inflammation, but now we have a clot formation. It can be caused by irritation from the cannula and some medications. We might see or feel redness, edema, warmth, a vein that feels hard or cord-like, or the client may complain of pain. It may indicate there's an infectious process going on. It does require discontinuation of the site and obtaining a new site. We should apply heat, analgesics, and anti-inflammatories. There is a phlebitis scale located in Complications of IV Therapy handout that's located in your resources in Blackboard. With infection, we may see redness along the vein or in the site area. We may see swelling or purulent exudate, warmth to the site. The client may have an elevated temperature. Cellulitis would be swelling or hardness of the vein with a purulent exudate and temperature. These do require removal of the catheter, and consider culturing that catheter tip and probable antibiotic administration. Occlusion. We may see a change in the flow rate, or the electronic infusion pump will alarm. The client may complain of discomfort. We can attempt to flush the catheter, but if we feel resistance, stop. Do not force a flush. We stop immediately and then remove the device. With a hematoma, there might be tenderness or swelling at the site, and we may see the bruising. Remove that device, apply pressure and cool compresses, elevate the arm, and reassess to make sure bleeding has stopped. With nerve injury, the client may complain of extreme pain like an electrical shock or shooting pain that goes up or down the arm. They may have paresthesia or paralysis or deformity. Stop the insertion, remove the device, and find another site. So then our systemic complications may include a bloodstream infection where we have a temperature over 101, chills, malaise, nausea, vomiting, abdominal pain, shortness of breath, and confusion. We administer medications as prescribed, obtain a culture of the catheter and or the exudate, and monitor vital signs. We may see that vasovagal reaction where the client reports lightheadedness or dizziness. Their skin is pale, or it can be hot and flushed or cold and clammy. We may have nausea, blurred vision, a pulse that is slow and weak, or blood pressure that begins to drop. Assess the client for syncope and monitor their vital signs. With circulatory overload or pulmonary edema, these clients may have pain, distension of the neck veins or respiratory distress, increase in their blood pressure and their heart rate, crackles in the lungs, edema, weight gain, cough, and restlessness. We should elevate the head of the bed and administer oxygen and slow down that infusion rate until we call the doctor and find out what they want us to do. Always use a flow control device if possible. A flow control device should always be used in the pediatric infusions. Speed shock is a sudden physiological reaction when IV drugs are going too fast. We push it too fast, or it's going at a rate that is too rapid. These clients may have a headache and dizziness, facial flushing, tightness in the chest, hypotension, or an irregular heart rate. Stop the infusion and, if necessary, call a rapid response. With an air embolism, we know an embolus is going to be a foreign object in the bloodstream. It can be a blood clot, air, a piece of the catheter, etc. The client will experience shortness of air, hypotension, chest pain, potentially shock or cardiac arrest. Again, if an IV cannula flushes with difficulty, do not force the flush because you may dislodge a clot. It is recommended to try and aspirate. We do know that 10 mLs of air can cause an air embolus. Very important to monitor your infusion lines closely to make sure there's not large amounts of air. If an air embolism occurs, turn the client to the left side, lower their head. This will help encourage absorption of the air into the right atrium. Notify the healthcare provider, administer 100% oxygen, and keep that emergency cart close. And with an allergic reaction, the client's going to have those itchy, watery eyes, runny nose, maybe bronchospasms, wheezing, a rash, anaphylactic reaction. Stop the infusion immediately and start normal saline. Maintain the airway, administer medications such as epinephrine, steroids, antihistamines, anti-inflammatories, or antipyretics. These are the nursing priorities that have the most impact on the client that is receiving IV therapy. They have a potential for injury that would include trauma, infiltration, or extravasation, a potential for infection from cannula irritation, medication irritation, or non-adherence to aseptic techniques. Fluid volume excess can occur in clients that have impaired renal or cardiac functions, or any infusion in which the client does not receive appropriate monitoring. And impaired circulation can occur from emboli or thrombi. When it's time to discontinue the IV therapy, it's really important to understand that just discontinuing an IV site does not require a provider's order. You know, if it infiltrates or the client complains of pain and wants it put somewhere else, that does not require a provider's order. Discontinuance of the IV therapy does require the provider's order. Nursing assessments that may indicate a need to discontinue the site include infiltration. The site is red, tender, indurated, or warm to the touch. We have evidence of thrombophlebitis. The vein may be hard and tortuous. The client reports aching or pain of the extremity. Site infection is evidenced by drainage. We have occlusion of the cannula, evidence of cellulitis, or suspected IV-related sepsis. We note a defect in the product. A description of the site should always be documented in the client's medical record. So to discontinue a site, hand hygiene, don your gloves, discontinue infusions or clamp the extension tubing, remove the dressing, the stabilization devices, and the adhesives, inspect the site, cover the insertion site with gauze or a cotton ball, and then slowly remove the catheter parallel to the skin. Apply pressure until hemostasis is achieved. Cover the site with a gauze, cotton ball, and tape it in place. Inspect the cannula, We need to visually determine if the length of the cannula removed corresponds with the length that was inserted as noted on the original documentation, and visually determine that the catheter tip is not jagged. If we suspect a piece of the cannula is missing, always assess for signs of an embolus. Then we provide instructions to the client to leave the dressing in place for a while, avoid rubbing, scratching, or bumping the site, and notify the nurse if renewed bleeding, pain, or discomfort develops. And don't forget to document your education. Record the appearance of the site, condition of the catheter, and how the client tolerated the procedure.